Let's get to the cases. Today we have from GI, Dr. Columbell, Dr. Marion, Dr. Kornbluth, and Dr. George. From surgery, we have Dr. Kaitov, who's coming in from Zoom. And then from pathology, we have Dr. Paulson. So first case is and I actually have a special guest who's zoomed in, Dr. Adam Fay from NYU, whose specialty is management of IBD in elderly patients. So he's going to also help weigh in on this case. So we have small bowel Crohn's in an elderly patient. So this is an 89-year-old who has hypertension, hiatal hernia, and likely Crohn's ileitis with stricturing, complicated by recurrent obstructions. So she comes for a second opinion. So she's had abdominal pain, gas bloating, constipation for years. Her first obstruction was in 2010. She was decompressed with an NG tube. Her family was told it was due to constipation, and then she never followed up, but basically had pain on and off for the next several years, requiring ED visits. In April of 2021, she has a colonoscopy with an outside GI, told she had thickening in the TI, and we don't have any reports, but her GI told her she was too old to have Crohn's. So she was given a bowel regimen, including a prescription medication for constipation, some antibiotics, and of course she doesn't get any better. A few months later, she ended up having an ED visit for pain, and her CT shows ileitis. In February 2022, she comes in with an SBO. The CT shows a thickened TI with significant upstream dilation. She's managed with an NG tube. A few months later, she has an MRE that shows 10 to 15 centimeters of terminal ileitis with areas of severe thickening concerning for Crohn's. She then sees a surgeon who offers a resection, but also says, why don't you go and see a GI and talk about potential medical management? The GI isn't covered by her insurance, so she never follows up. December 2023, she goes in again with an SBO. There's a clear transition point at an area of ileal thickening. She started on a budesonide taper and discharge, but she can't tolerate the budesonide, so she stops it. These are images from her most recent CT scan. You can see on the left the thickening of the terminal ileum where the arrows are, and on the right, the extent of upstream dilation of the small bowel.
How much is it? I can't see.
It says 5.7 centimeters. Quite dilated.
I thought that was the liver on the left.
So she subsequently has an MRE. It shows marked wall thickening of the distal TI. It's a long segment, approximately 20 centimeters. Thickest segment is 10 to 20 centimeters from the ileocolic junction. And the findings are concerning for acute on chronic IBD. She has associated marked intraluminal narrowing, suggestive of a stricture, and marked upstream dilation of the mid-ileum, measuring up to 6 centimeters, containing differential air fluid levels, suspicious for obstruction. She gets a colonoscopy after, and everything is normal. But remember, the MRE says that the disease starts at least 10 to 20 centimeters from the IC valve. So unfortunately, it doesn't really help us that much for an endoscopic diagnosis. She comes in for a second opinion in September. She basically feels at her baseline. She has chronic distension. Sometimes she feels like she's obstipated. She's losing weight because she's not eating because she's afraid of obstructing. So here we are, 89-year-old woman. She's relatively frail. She's 114 pounds. She doesn't have a lot of comorbidities, but she's not like very hardy 89. And her daughter wants to know, like, should we attempt to do medications before we take her to the operating room? And also, if we're going to do that, how does the fact that we've never had a pathologic diagnosis of Crohn's impact our decisions about management?
Doesn't matter what she has.
Can you explain more what you mean?
Doesn't matter if she has Crohn's disease or carcinoma of the small bowel or lymphoma of the small bowel or whatever it is. She's had repeated obstructions. She's losing weight. She's got markedly dilated loops of bowel. She's not going to get better with medical therapy. She's going to just lose weight and decompensate if you don't operate on her. And she's going to become more medically frail to operate on if you just keep waiting.
I would agree with Jim. Let's say she has, Yersinia from drinking raw milk. She has enough end bowel damage here to justify removing that segment.
I think I completely agree. It doesn't matter what actually is. She's obstructed, so whatever the cause. So I think the only way is surgery. The point is all about the surgeon, anesthesiologist, and so on. And maybe this is where we could ask Adam, who is specialized in the care of elderly patients and doctors. No, sorry, only elderly patients.
Right. I'm going to ask before Adam, you weigh in. Dr. Kaitov, can you weigh in on your thoughts about operating on this patient?
Okay.
I assume you can hear me, you can see me, right?
Yeah.
Yes.
Okay, excellent. So here's the story with this. She's 89. So when you were presenting the case, there is a very nice tool. It's called ACS Risk Calculator, which calculates the risk of complications and adverse outcomes in patients who have surgery based on all the parameters you've just told me. So actually, for this patient, it's unlikely that she will die. Her risk of death with surgery will be 1.5%, as opposed to regular risk of iliac colic resection, 0.3%. The main risk for this patient is discharge to nursing or rehab facilities. So basically, what we're talking about, she needs an operation. That's pretty clear. Whether she had Crohn's disease or lymphoma of her small bowel, or Crohn's disease with a cancer of the ileum, that's to be determined on the final pathology, I would say. I was able to see her whole imaging. It will be about 1 foot of the terminal ileum. So the family and the patient basically have to decide their goals of care. So if there is a risk with the surgery, but I think it's totally indicated in this patient. She's likely to be able to tolerate the operation. There are 2 things which I always tell the patients of this age group. Number 1, even with a successful surgery, they may not be the same after the operation. I'm talking about performance status or mental capacity. Sometimes is affected. It's just irrelevant to anastomotic leak or any other complication. And number 2, patients with borderline performance may end up with a nursing home. Those are main risks. Yes, there is a risk of leak, ileostomy, et cetera, but other than surgery, I have serious doubt that any, 89 years old, without diagnosis or with this extent of disease, with a bowel obstruction, to put her on medicine, I'm not so sure. I would offer this patient surgery, or they have to decide what their goals of care are.
Yeah.
Absolutely.
And Zoe, I will add that even if we are certain this is Crohn's disease, no medication will work on that.
Absolutely. So I think the point to emphasize there is that there's clearly an element of fibrotic disease here. So sometimes when people have stricturing disease, if it seems to be largely inflammatory, you can consider managing them with medication. However, when there's a fixed upstream dilation, there's an indication that this is a chronic scarred or otherwise really damaged small bowel that's not going to get any better with an anti-inflammatory. I think that's an important point to be emphasized in this case. Adam, Dr. Fay, can you weigh in a little bit about your general approach to the management of elderly patients with IBD?
Hey, Adam.
Good to see everybody. Hi, everyone.
Sign a celebrity here.
Celebrity.
I completely agree with everyone, by the way, including with Sergey. Although I will say the ACS surgical risk calculator, at least the studies in IBD, showed that the AUC is pretty poor for it. So we're actually doing like a preoperative risk calculator where we're enrolling like patients who are 60 and over at our IBD center and doing a lot of frailty and sarcopenia measures to try to figure out a better risk tool for them. I think another key is, so I just sent an 83-year-old to surgery who it was questionable whether it was SCAD or whether it was Crohn's disease, but similar case in the sense that it had been going on for a year, he'd lost weight and become frail. I think another key element with these items is that you really don't want to delay. I think this person has now lost weight, they've become frail. Perhaps if this was a year or so ago or 18 months ago, they actually may be in better shape, both cognitively, physically, nutritionally, to actually recover. So I also think surgical delays sometimes contribute to some of the complications that we actually end up seeing, because we're only really willing to go in and intervene when push comes to shove. Either they come in with a perforation, or now we don't think medical therapy is going to work and they've been having repeated SBOs. So that's one thing I like to ask, like, are you losing weight? A lot of times patients say, oh yeah, I feel okay. And then I'm like, okay, but what are you eating? And they tell me that they're basically not eating anything to feel marginally well. So I think honing in on that also is important. I completely agree medical therapy is not gonna work. Even if medical therapy is gonna work, and this is a 79-year-old, I also think about the potential that in ICR, especially with the data that Monty, John, Fred, and we all showed, that you can obviate the need for future immunosuppression potentially in these patients, which I think we can discuss, risks and benefits of that. There was one other kind of point I was gonna mention. Oh, in terms of prehab, so that's another space that we're actively engaging in. So can we actually modify, short-term and long-term risks with preoperative intervention, whether it be rehab, nutrition, cognitive exercises, and so forth? That remains to be seen, but there's a lot of interest in the jury world and in the surgery world about this. So I think it's an exciting kind of area to explore.
Thank you so much, Dr. Fay.
I think there was.
Yes, Dr. Rubin, we wanted to give you, did you have a question?
Well, I was relieved that when Jim said it really doesn't matter, I didn't know where he was going with that. So I'm glad he agreed that she needs surgery. Has she had the surgery yet?
No, she has not.
Okay.
She's planned to get repeat MR enterography since the last was like 9 months ago. But, and she also understood that her case was being presented today and wanted to hear a panel of expert opinions, and her family did too. But she was encouraged to undergo operative intervention.
How much does she weigh now?
114 pounds.
Oh, that's
Yeah.
the most recent one, okay.
So I'm not surprised that Sergey is the one who's the most sensitive and delicate among us. And I'm fascinated by the prehab. So there's two expressions I use, and he really reminds me of the most important one. Well, one of the two. One is I tell a patient I'm not looking for a new normal, not this patient, because she's the other expression. New normal, I tell the patient, my new normal should be like the old normal before he had IBD. So I try and give them hope and if I could achieve it. In this patient, she ain't going to have a new normal like the old normal. And I think to sum it up, you have to manage their expectations, because I'm very worried for all the things. In Sergey's hands, this patient will probably, quote, sail through surgery, maybe go home post-op day 5, 6, but then she's going to lay in bed, she's going to get her pneumonia, she's going to get her decube, she's going to get an aspiration. Managing that expectation, especially with the family, and he's right, these end up in nursing homes, rehab, etc. It's not the operation, it's the complications, and not even in hospital complications, but when they go home. We don't see these patients, especially if they're coming in through the hospital, through a clinic. That's her real demise.
Absolutely, and that's the same sort of thing you can apply in general medicine when people come in for a total hip replacement. You see the same kind of sort of morbidities. Obviously, that's not an intra-abdominal surgery, but people have a prolonged recovery where they're not as mobile, and when they're elderly especially, you do worry about things like infection, pneumonia, and just debilitation. So I do agree. I think the panel was I really appreciate that everybody was on the same page about a resection, because I think this case is really not one where there's much up for debate. But I think it is important to remember, and I'm really glad Dr. Fay was able to come and weigh in, that we have to think about these patients. We can't just say first of all, like somebody told her she's too old to have Crohn's disease. Remember, we know that that's not true. But also we have to think about these patients the same way we would think about anybody. If you're having recurrent obstructions with a fixed stricture, your risk of having a severe complication is way too high to forego a surgery. So thank you all on that one. We're going to move on to the next one unless anybody else wants to comment on this one.
Alana just asked if anyone would consider pre-op TPN.
No.
If possible, not. I think we should ask
Dr. Gold?
nutrition, but I would avoid any kind of TPN in an 89-year-old.
This patient is going to have a consult with Dr. Gold in the IBD nutrition clinic specifically due to profound weight loss. As you mentioned, in terms of what she's eating, Dr. Fay, she's having like very minimal like mashed potato pureed things.
Yeah, I mean, there's some data for TPN, there's some data for shakes, which we started doing a couple of days before and post-operatively. But I think the key to a lot of this is timing, and I think even the hip replacement is kind of a nice example. It's like you may not want to operate on someone who's 90 with a hip issue, but if they're going to spend the next year not walking around and physically declining, that's really not a good option for them either. So actually intervening in this person before they become malnourished, before they've physically declined over the last year and a half, and now when Sergey goes in and does an amazing job at surgery and she's home and she's not able to get up because the last year she's incredibly malnourished and physically declined, you can imagine if the surgery potentially were a year and a half ago or so, that the outcome could be very different then.
Absolutely. We're going to move on to the next one. Unless there's...
Next one.
Sorry, Adam,
Yeah,
did you
yeah,
have
yeah.
something else that you wanted to say?
No.
Okay. Sergey, did you want to say something else?
No. I totally agree with the comments. Her albumin is 4.1, so it's not the greatest measurement of her nutritional status, obviously, but it's not outrageously low. To be, as just a number from a few days ago. So I think anything other than TPN should be considered.
Absolutely.
But her BUN was 60. You're
That's
kidding.
old.
No, we don't know.
I'm teasing.
Okay.